All right, let's get going. Welcome everybody to our latest installment of the Implementation Science Working Group. I'm pleased to welcome you on behalf of Karen Emmons, Becca Lee, Julie Laufenberger, and the rest of the organizing committee. And so, as promised in the notes that you received from Trong, with many thanks to her for coordinating the outbound and the challenges with the calendar invites on this particular occasion. We were hoping that this would be an introductory session for as a preview to what will hopefully come next month, in which we're going to talk a little bit about theories, models, and frameworks, and the many of them that there are in implementation research, and the kind of dizzying array and how they connect. There are some people on the Zoom who are highly experienced with these models, theories, and frameworks, and we welcome your contribution. But what we were really hoping to do is take a couple of minutes, which I will lead, to orient, at least provide one orientation to how these things fit together. And then with thanks to Lydia Pace, who I think will be joining shortly if she's not here already, to Karen and to Julie, we're going to take each one of them is going to take a specific type of model and give us an example of how they're used and a little bit about a little orientation to them, just to give a little more practical flavor to what these things are about. We hope that the formal part will probably only take about half an hour or so, and so we should have lots of time for discussion as we go. So with that said, I'm going to offer you what is at least my adaptation of what appears in the literature, and a lot of what I'm going to share today comes from two excellent papers, which I've cited here below, and you'll see them throughout these slides. That there's sort of there are a series of phases or a process in implementation research, and that the models, theories, and frameworks then kind of overlap on these processes. So we begin with some sort of evidence-based healthcare behavior, like weight loss is good, or procedure, like taking a statin after an MI is also good, or opioids are bad for uncomplicated back pain. We then have some intervention to improve the use of that procedure or behavior, and for our purposes today, we can call that an evidence-based intervention. We then want to have that used more in practice, and we call that as sort of an implementation approach. And that ultimately leads to improved outcomes. And so what the theories, models, and frameworks then kind of overlap on this, that we have a bunch of different ones, and different people call them different things. But Nielsen sort of nicely labeled a bunch of these, and I'll define these in more detail. But classical or implementation theories help us in developing evidence-based interventions. And I will acknowledge that the use of these may be part and parcel of the development of the evidence-based intervention, and may not be used by everybody. There are process frameworks which discuss the method of going from an evidence-based intervention to an actual implementation approach. There are determinant frameworks which look at moderators and mediators and are often overlapping with process frameworks. And so we'll hear an example today where the same framework can be used for more than one thing. And then there's implementation frameworks, evaluation frameworks, which I'll acknowledge, and I'll show you an example or two of, but which won't really be the focus of our conversation, but just for the sake of completeness, to figure out where they fit in this arc. Now, you'll see other sort of similar representations of this kind of flow. This, to me, at least, is what makes sense to me, but it's really not that different from what you may see in the literature. So before we go into these things, worth a reminder, especially for those of us that forget, which is me routinely, what is a theory, what is a model, and what's a framework, and how are they related? And I sort of take these definitions again from this Nielsen paper, that a theory is a set of analytic principles or statements designed to structure or our observations, understanding, and explanations of the world. And so it provides a clear explanation of how and why specific relationships between variables, which is sort of broadly defined, leads to a specific event. And so it is abstract in its definition, and in some cases in its practice, but it's a meta principle. whereas a model is a simplification, and there's a lot of overlap between a theory and a model. And it is descriptive, whereas a theory is sort of meant to be explanatory. And a framework is a structure or an overview, an outline, a system, some sort of a process which is not really meant to provide explanation, but really just more of an empirical description of how things fit together. And so from that perspective, these terms all have a lot to do with each other. And there's some things are called theories, which may well be models. Some things are models, which may well be theories. I think the framework perhaps is the most distinct from them all. And I think hence, at least from my observation, this idea of theories, models, and frameworks almost being like a word salad that comes out of TMF, which probably could stand for all kinds of other things as well, is a sort of representation of the fact that sometimes we use theories, sometimes we use models, sometimes we use frameworks, but they're all largely in specific instances trying to achieve the same thing. So with that said, just as a way of setting the table for the others to provide much more content, these sort of the things that help us develop evidence-based interventions can either be considered as classical theories or purpose-built implementation theories. So classical theories are the ones that we all learned in psychology, things like the health belief model, and things along this family, classical behavioral theories, which may be useful, as opposed to implementation theories or implementation models, which are really more specific, purpose-built. And Julie will introduce us to this particular one, the behavior change wheel, or the COM-B model, the capability, opportunity, motivation model, and as a specific example of how we go about this. The second sort of step in this process are these process frameworks, and process frameworks are more formally defined, are used to describe and or guide the process of translating research into practice. So they're really, how do I go about then getting the thing done? And so there are lots of these. So one that my colleague and friend Josh Metley likes a lot, which I like a lot, is called PROCEED. It has a series of assessments, and you'll see this in other process and determinant models, which are basically a series of steps and which one would go through in order to figure out how to deploy an intervention into practice. The next step are these sort of determinant frameworks, and I put them sort of below the process and evaluation frameworks because they're either used to develop the process or they're used in the evaluation, and sometimes both. And so the granddaddy in this case is the CFR, or the Consolidated Framework for Implementation Research, and Karen Emmons will try and tackle that one. So last in the spectrum, and again with just to give the landscape, are these evaluation frameworks, and the one that of course many of you are familiar with is REAIM, which we talked about in a prior session. We'll probably talk about again as an equity adaptation of this has happened, or there's evolutions in this sort of modeling approach as well. So with that set up, again, our goal today was to take examples of these and describe their use and provide a practical example. So I think Julie was probably going to go first. Yep. And then Karen was going to go next, and Lydia will do our hybrid determinant process after that. And again, with all full acknowledgement that what goes in what bucket is to some extent in the eye of the beholder, both because the models themselves or theories or frameworks are broad, but also in their application may differ. And I hope that's something we can get into in the discussion. So with that said, I'm going to stop sharing, and Julie, I will turn it to you.
All right, sounds good. Hopefully you're able to see my screen. And so I'm just picking it up where Natish left off and giving you an example, as he alluded to, of the COM-B model, which is one of those implementation theories specifically about how we design interventions that individuals can use. And so the first thing just to note is that, we're talking, leveraging the idea that he was getting at, which is that these types of models often link barriers to specific strategies. And so when we refer to this COM-B model, it's really in this behavior change wheel framework, the way that I've thought about understanding it is just kind of that the COM-B model is sort of informing how this behavior change wheel is really set up. And so COM-B really stands for literally capability, opportunity, and motivation, and how that affects behavior, COM-B. And as you can see, we'll kind of talk about the 3 different rings and a brief overview of each of these. But as defined by kind of the originators, I suppose, of this model, and then subsequently the framework a few years later, capability is really kind of psychological and physical attributes of a person that together kind of facilitate behavior or our particular targets. Whereas opportunity takes into account social and physical factors, really attributes of environmental systems that together make behavior possible, along with motivation and capability. And then what they mean by motivation is that it's an aggregate of different kind of mental processes that influence behavior. And here they define that as automatic and reflective. To me, it's a little similar to if you've heard of system 1, system 2 thinking, kind of similar ideas behind that. And so the different elements, just to give you an overview, this inner layer is what are the sources of behavior. And I've lifted, obviously, some screenshots to help kind of understand this a little bit more. And so kind of outlining these physical, psychological capabilities that affect capability, which all kind of influence behavior. Then there's the reflective and automatic types of motivation that influence motivation. That ultimately influence behavior, as well as opportunity and the physical and social opportunities that ultimately influence behavior. Really, the point is that this inner layer, these different sources of behavior that all interweave themselves against each other. The middle layer then, surrounding this, surrounding the inner layer, really what they call the intervention functions. And that there are really 9 intervention functions that they've outlined that one can choose. Based on the particular sort of analysis that you've done to sort of understand what intervention might make sense in your and what's relevant for this intervention. And I should say that the original model was really based on kind of 19 different key models that individuals or theories that people are using behind behaviors, and based on an original systematic analysis in the first place. And so there's really these 9 different intervention functions, things like education, things we've commonly used in these different types of interventions that we've used in this space, training, incentivization, thinking about incentives, things like that are kind of these functions that are outlined here in the behavior change wheel or the COM-B model. And that these intervention functions are what we are translating specifically for how we have techniques that ultimately change behavior. And finally, the outer layer are the different sorts of what they term policy categories, which wouldn't necessarily be what I would always call a policy category, but 7 policy categories that ultimately support the delivery of different interventions. And so these are kind of wrapped around what the intervention devices are, which are wrapped around what the individual behaviors or targets that one might actually be seeking to do as part of an intervention. To give you just a quick example of an example that the authors used and published just a couple years ago. And I chose one just in COVID transmission, since that is something that everyone should be relatively. And so early on in 2020, they published a paper kind of adapting this COM-B model or the behavior change wheel to thinking about different intervention targets to reduce COVID-19 transmission. This was pre-vaccine, for what it's worth. And so here's really just kind of where they've outlined the different types of targets that could have been addressed for addressing COVID-19. And so when we then think about the different behaviors that are critical to preventing COVID-19 transmission, then from what they identified based on what they clinically had learned and where we had been in terms of the pandemic so far, they outlined different behaviors and how that maps onto these COM constructs, basically capability, opportunity, motivation. So to take maybe the first row, as an example, only coughing or sneezing into tissues and safely disposing them. Capability would be addressing or considering the ability to cough or sneeze until a tissue is there. Opportunity would be making tissues readily available, including other preparatory actions like having a nudge and carrying it with you, or just really having facilities where tissues could be disposed. And then finally addressing, one could address motivation, which is that, people must feel like they need to have tissues and self-train it so that becomes habitual. This is just an example of mapping the different elements of COVID-19 transmission, how that could be addressed. So from there, how would that actually look for an intervention? So then taking the middle row. So if we take, again, our first behavior that they outlined, their analysis of an intervention that might work within this COM-B model is that kind of focusing on education, training, enablement to improve capability or the ability to do this, delivered through mass media, social media, online videos as a way to show this is one example of an intervention that might work, and that we're kind of working through different policy levers that we have. So just the kind of the end, of course, there's different criticisms of this model. It's been 2,000 times. I just looked it up today. But of course, there's criticisms of it, just really kind of thinking more about representation, especially variability in people. This speaks to some of the equity things that I'm sure we'll cover later. That there are differences between what people believe and what they actually do, and that this model somewhat assumes rationality, and that it has been criticized a little bit by where stakeholders should be involved. So I'll stop there as just kind of an overview of one of these different types of frameworks.
Excellent. Great. Thank you, Julie. Karen, over to you, please.
Great. Trang is going to run my slides for me. Thank you, Trang. So I'm going to give you a very brief introduction to the CFR, the Consolidated Framework for Implementation Research, and should note that this is the original version I'm going to talk about today. We have an upcoming session where we're going to deep dive into the recent update of the model, but we wanted to kind of start with, I think, probably what most people are familiar with and give you the groundwork of that model that then the new update builds on. So I guess 19 is the magic number for consolidating and doing developing frameworks. So this also draws on 19 theories, models, and frameworks using snowball sampling to identify studies to look at and try to develop a consistent use of constructs, terminologies, and definitions to look specifically at what are the factors that might get in the way or facilitate implementation. They came up with 5 domains and 39 different constructs. And I should say this is really, CFR is among the most widely used frameworks in the implementation space. Over 350 studies contributed to this work. So that's basically the purpose is to really provide a pragmatic organization of these constructs. And as a determinant framework, it really helps to identify and explain the factors that influence implementation. It's a list in a sense that really gives you a sense of where things are at. Oh, thank you, Trang, for moving forward. So we're really sitting in the determinants bucket. You can go to the next slide. Sorry, I jumped ahead there. Yep, keep going. Perfect. Okay, catching up with myself. So this is really the background on what's come into the CFR model. You can go on to the next slide. So you've seen this picture a million times. These are the 5 domains that we have in the CFR model. And I'm just going to walk through them quickly to make sure everybody understands what each of the pieces are. Up in the top left corner is the intervention. And if you have been drinking the Jeff Curran Kool-Aid, it's the thing. So the intervention is what the thing is that we're trying to implement. So questions that come into place here are that you would want to know to understand what's going to facilitate or be a barrier to implementation would be things like, well, who developed it? And are those people trusted people in the setting that we're going to be working in? Is there evidence for it? Can you take a bit of it and try it out to test it? Is it trialable? Can you adapt it to your setting? Does it offer an advantage over what we're already doing? That's a huge thing. If it's just a little tiny advantage, then are people going to look at this intervention as something they want to really embrace? And what is the cost? Then down in sort of the middle, the lower part is inner setting. These are the characteristics of the implementation setting that you're trying to get this thing used in. And here you're asking questions like, what are the structural characteristics of this setting? And what are the cultural factors, the cultural characteristics? How do networks work within this setting that we're working in? How does communication flow? Are people game for doing this sort of thing? What's the implementation climate? Do people get excited and feel they have resources to try new things and to do new things? So is there a sense of this tension for change, and which is supposed to be kind of a positive thing. Is leadership engaged? Are there resources set aside to help people be able to do this in this setting that they're being asked to do? Then in the very middle are the individuals involved. And these are, in the CFR model, we're really thinking about predominantly the people who are the implementers. So the people we're asking to do this, did they believe in the thing, in the intervention? Did they have self-efficacy about their own role and ability to do the implementation? Do they feel like what they're being asked to do is something they can do? Do they identify with the organization such that as the organization asks them to do this, that's something they want to rise to the occasion? Do they have a commitment to doing things that are important to the organization? Then on the very bottom is the process. And this is kind of an interesting aspect of this. This is sort of how was the implementation process handled? So often you might be thinking about this in the beginning, like, how are we going to do that? And then when you're trying to look backwards and say, what happened here that led to whatever the outcomes were in implementation that we had, you would be looking back and seeing what happened in that process. So how was it handled? Were there implementation leaders? Were the right people engaged? Did we have the level of engagement over the long period of time that we needed, and so on? And then lastly, up in the top is the outer setting. And the outer setting, as really identified within CFR, are things like our patients' needs and resources that could constrain their ability to respond to the implementation. Are those considered? There's this concept of cosmopolitanism, which is really, are they networked? Are there external networks between the organization and other places where they can get ideas and information that might help them? Are there external incentives? I do a lot of work in community health centers, our team does, and there we might look at what the HRSA is asking the health centers that they fund to do. That would be an external incentive. So if there's a requirement to have a certain level of screening, then that's going to be an incentive to actually get engaged in the work that we might be asking them to do. I wanted to note that from an equity perspective, several of us in our Implementation Science Center for Cancer Control Equity think about outer setting just a little bit differently, and that is to also bring the broader social and structural environment in which patients and staff live and work that is going to impact on certainly staff's ability to implement something, as well as patients' ability potentially to respond to whatever the thing is. So social vulnerability, access to healthy environments, housing quality, all of the things going on that we often think of in a social determinant space that are important. We think that's actually an important part of the outer setting that we need to think about as well. Okay, so we'll go on to the next slide, and this just shows you the elements sort of in order. I think it's helpful to see them all kind of laid out and defined, with a note that this is not linear at all. The idea behind CFR is that things interact. Kind of the individuals are kind of in the middle of all this other melee. They don't lay out any prescriptions about how the interaction should occur, just that they believe that this will happen. So it's just helpful kind of to see it all together. If you go on to the next slide, I wanted to talk through an example. And this is coming from a paper that Laura Damschroeder, who was really one of the designers of CFR, did a few years back that I thought was interesting. And I should say at the outset, you can use CFR on the front end, the back end, or both. So you can use it as a planning tool as you're putting your implementation study together, to be thinking about what are the aspects of each of these domains that we need to be paying attention to, that we think are important and should be integrated into our choices of implementation strategies and our approach overall. You can also use it in the back end to say what happened here. And so this was a study where they are mostly looking at backwards to say, all right, what happened here? This is called the telephone lifestyle coaching intervention, where this was through the VA system. And so they were trying to improve healthy lifestyles that had 6 different components to them, 6 different behavioral targets. And they did that through coaching calls with staff at the VA over 6 months. So they were trying to get these staff in 24 VA facilities across the country to offer this lifestyle coaching program to their veteran patients. So it was a huge program, 9,000 veterans referred, because who doesn't love a good outcome? Just to tell you little outcomes, about 57% completed at least one coaching session with a trained coach, and there was, a reasonable rate of self-reported lifestyle change, although the data was only self-report. So if you go to the next slide. So the implementation strategy, as they define it, is basically that they had a formal MOU process. They identified implementation leaders at each of the demonstration facilities, and these folks were already involved in the prevention and patient-centered coaching activities there. They had kickoff orientation and lots of ongoing trainings, and then a whole bunch of other stuff. They have a giant list of things that they did, including things like setting up their, a new referral pathway and processes and other kinds of training activities. But this is sort of how they've described it as the highlights, with some other implementation strategies built in. Go to the next slide. So they were looking at what is the relationship between these CFR constructs and their outcomes. And their primary outcome for the implementation was the referral rate. How many patients in each of these facilities got referred to the TLC program? They did a mixed methods evaluation, so I'm going to show you a little bit of their data and then a little bit of their qualitative findings. They looked at all of the 5 domains. They found that the intervention characteristics in the outer setting did not have any relationship to the referral outcomes. But they did find that the structural characteristics primarily had an impact here. And an example that they noted, they did quite a lot of analysis in the paper at the individual facility level, looking at the highest referral centers and those with the lowest referral rate. And they found that one facility that had one among the highest referral rates had consolidated management of all their prevention programs under the leadership of one of the implementers of the TLC program. So providers could refer patients into a single pathway, and then patients had the option to look at all the different programs and make choices. So they felt that was a really a facilitating factor in terms of a structure. Those with the lowest rates, referral rates, had many challenges, including like the inability. They had to basically get in line. So they weren't able to market the program because the particular clinics were going through transition to a patient-centered medical home model. And so they just weren't really allowed to do much to get patients in. So those structural characteristics were quite of an issue. If you go to the next slide, please. Just an example in the low recruiting site, this issue of also where centers were located. This low recruiting site saying, we're in kind of a rural health place. We thought we'd kind of start with the hardest ones and roll it out there, but really they didn't have what we needed. So they just didn't have the resources. And then we kind of really had to change our approach, and we kind of left them and went to the primary facility and not the sort of outposts. If you go to the next slide, just 2 more quick slides. Thank you. The process domain was the other domain where they had quite a bit of an impact in planning, implementation, and key stakeholders. If you go to the quotes, I think they really sum them up. I want to wrap up quickly here so we can have time to talk. But in the high recruiting sites, they're talking about really this very effective engagement of the implementation leaders with the potential implementers. And this person who is one of the implementation leaders said, I talk about this thing nonstop. I do it in everything I do. I do it in every kind of teaching I do. I bring it up, not just when I'm having a conversation about this. I have information that I'm passing out constantly. I'm constantly looking for opportunities to highlight this program. So that is really the engagement of the implementation leaders as so important. If you go to the next slide, I love this quote. I went into this, kind of naively. This is a low recruiting site. I thought, I'm coming with gifts. Everybody's going to be so excited and they're just going to do it. And I really didn't follow through. That just wasn't enough. And I think many of us go into our implementation efforts thinking, how could they not want to do this? But again, that gives you a sense of this sort of the key stakeholder engagement was lacking in this site through the way the implementation leader was handling it. So those are some examples of just how this has been used on the back end to try to figure out what happened. So thank you.
Awesome. Thank you, Karen. And last but not least, Lydia, thank you so much for joining us to talk about EPIS.
Lydia, I can't hear you. I don't know if others can.
I'm on my phone now. Is that working?
Perfect.
Yes.
Great.
Sorry. Okay. Sorry, this is a clinic computer, so I don't even know how to use the microphone. But you're hearing me now? Okay. So I'm going to talk about the exploration, preparation, implementation, sustainment framework, or EPIS. And this was actually, I am so grateful for the opportunity to talk about it because it made me realize some missed opportunities that I have to use this. So thank you. So this framework is unique and interesting because it really focuses both on looking at a process of implementation and specifically phases of implementation, and also determinants. So it kind of includes opportunities to look at both those processes and determinants of each step of implementation. And I think that allows us to consider the fact that different determinants or different factors will affect different aspects of the implementation process. And the designers of this framework consider process in 4 distinct phases. So exploration, they identify as needs assessment, identification of a need, and starting to think about what specific evidence-based processes, evidence-based interventions would serve to meet that community need, for example. Preparation is starting to design the evidence-based intervention and starting to think about what implementation supports are needed, for example, training. And then implementation is incorporation of that evidence-based process into systems of care, for example. Sustainment is the ongoing maintenance and continuation of those supports, those implementation strategies, and the necessary systems to continue the intervention over time with adaptation as needed. Another thing that I think is unique about EPIS is that it includes a lot of very similar sort of contextual factors that Karen explained. So outer context, they define very similarly as representing the systems, policies, funding environment, also client or patient factors that may impact how an intervention is implemented. Inner context, they define similarly as being aspects of the implementing agency, the clinic, the clinicians, organizational and individual characteristics, staffing that may impact how an intervention is implemented. And then innovation factors similarly are characteristics of the actual intervention, including how well it might fit with an organization's individuals, workflows, culture, as well as patient or client needs and culture, values. Who develops the intervention, that's very similar to CFIR also. The thing that I really like about, another thing I like about EPIS that I think is somewhat unique is that it also includes room to think about bridging factors. So these they define as characteristics that really facilitate the complex overlap between both inner and outer context. So some examples that they give are community academic partnerships. So organizations or groups that may support the implementers in actually carrying out an intervention. Purveyors or intermediaries, the example that they give is pharmaceutical companies. For me, I think this might be more of like a nonprofit organization that might help a clinic, for example, meet a quality goals, for example. But I really like this recognition that the inner and outer context are not distinct, but actually it's a very dynamic relationship, and they are speaking to each other, impacting each other constantly. And overall, I think it makes for EPIS being a very sort of dynamic model that allows you to recognize that none of these relationships are static. They all will evolve as an intervention evolves as we go through implementation. I probably should have provided a perfect example of researchers' use of EPIS, but I am instead providing an example of how I chose to use it, and maybe some reflections on how I could optimize it a little better. So we have a National Cancer Institute DNI R21 examining scale up of a women's cancer early detection program. This is an intervention that was really centered around integrating breast and cervical cancer screening. It has evolved a lot over the past 10 years, starting with a pilot intervention that we tested in a cluster randomized trial in a single district. And that intervention was focused specifically on facilitating earlier diagnosis of breast cancer among women who had breast symptoms in the community. And the intervention focused on increasing community awareness through use of community health workers and sort of messaging at community fora, and building primary care clinician skills and clinical breast assessment and prompt referral, and then also building district hospitals, so kind of local hospital capacity to conduct diagnostic breast ultrasounds to avoid having to refer patients to the capital city for imaging. Since that time, which was 2015 to 17, this intervention, components of this intervention have been scaled, and now it's actually being implemented in 23 districts in Rwanda, so about 50% of the country. During the process of scale up, the Ministry of Health and partners have had several adaptations, but two that I sort of identified as key for this project. One was that they integrated breast cancer early diagnosis with cervical cancer screening, so that everyone who was coming for cervical cancer screening, which initially was women aged 30 to 49, also received initially a screening clinical breast exam, but in this phase of the project, they received a clinical breast exam if they described breast concerns. And then secondly, development of a new electronic health record that was to be used by primary care nurses at rural health centers on tablets, and then but also had the capacity to link to a hospital-based EHR using the open source software OpenMRS. So the goal of that EHR system was to be able to track patients from the health centers to the secondary level hospitals, so that we minimize loss to follow-up, which is a major issue, of course. So loss to follow-up of individuals who had abnormal screening tests, a major issue in the United States, even more major issue in sub-Saharan Africa, where particularly because patients have such incredibly limited resources for transport, compounded with a lot of other barriers to care. We anticipated a lot of challenges with scale up, including sort of a lack of dedicated funding specifically for this women's cancer early detection program. The government was going to rely on sort of a patchwork of funding and support from various nonprofit organizations. As always, our primary and secondary health systems in Rwanda are understaffed and under-resourced. Clinicians face a lot of competing priorities, including very pressing clinical demands. Use of an electronic health record was totally new for all of the health center staff that we were working with. And then lastly, there's limited understanding of the benefit of integrating cervical cancer screening with breast cancer early diagnosis. And that is a topic for a whole other talk, but there are challenges and opportunities with that. One potential challenge is that you're potentially really targeting a younger group of women who are potentially at somewhat lower risk of breast cancer. So for our R21, we propose to use the REAM framework, which I think we're not talking about today, or Nitish talked about a little bit, to examine implementation and impact of the adaptation and scale up of this early diagnosis program. So really focused on reach, effectiveness in terms of linkage to care, less so on maintenance. And then we propose to use EPIS to guide interviews with policymakers, NGO partners, and facility leaders to understand contextual factors related to successes and challenges of scale up. So we really propose to use EPIS focused on its determinants and less so on the phases of implementation. And when in the recent 3 years ago, there was a systematic review of EPIS that identified that more and more researchers are using EPIS, but most of them actually are focused on either a single or two phases of the implementation process, and 75% of the papers that they reviewed focus on implementation. So I think there's a lot to talk about why that is, but it gave me a little bit of, it heartens me a little bit that I wasn't the only one. But I want to flag that I do think that this is a little bit of a missed opportunity potentially, and that I think so our interviews, which we've just completed but haven't started analyzing, have focused on outer context. A lot of it has been outer context because we chose to focus on policymakers. We had, by the time we got this funding, we had conducted other interviews with clinicians and patients, which is why we focused less on them. We look at innovation factors, and then we will also look at some inner context factors as well. But I think there may be ways that we can also examine kind of retrospectively how these factors did impact planning, for example, of scale up, and then to a lesser degree, starting to think about sustainment. But I think the fact that I focused on implementation and the fact that many people focus on implementation really highlights that we're usually kind of, as researchers, we're often intersecting with an intervention at one sort of specific moment in its history, especially in my case, which was a retrospective study. We rarely have the luxury to be involved with a project for 10 years, for example, like over its entire life cycle. And so, I think ideally, if you were really able to be involved in a project from exploration to planning to implementation and sustainment, I think this might be a really, really rich opportunity to look how the relationship between these factors kind of evolve over time. It's a luxury that many of us don't have, but I do hope to be able to do it a little bit with this project through analysis of the interviews. I'm not going to go a ton through our findings, but I think one thing that and I sat in on a few interviews, and I think one aspect that I think will be really nice about using EPIS is just the way that it has prompted us to think about the relationships between the different factors. And specifically, there have been a lot of people have talked about fragmentation of partners and the way that different NGO partners kind of own different districts and focus on implementation in specific districts. And there's not always a seamlessly coordinated initiative. Funders are often quite siloed, which leads to a more piecemeal intervention. And so I think this focus on bridging factors and the relationship between all these determinants, I think, has given us a helpful way of thinking about those relationships. But that's really it.
Great.
Thank you.
Awesome. Thank you so much, Lydia. So I think we have the balance of the time for questions. I'm going to take the prerogative and ask one question of Karen and one question of Lydia, because there's parts as I was listening, and absorbing. Karen, to begin with you, there are ways in which you can think about the example, the CFR example that you gave, which overlap to some extent with evaluation outcomes like implementation and re-aim. And similarly, Lydia, obviously EPIS is this process and determinant thing that you could use it to figure out barriers and facilitators in the determinant way, or you could use it to design your intervention in a process sort of way. And so maybe, Karen, I'll have you go first, but Lydia, would love for you to tack on and just, so the confusion is, because these are all created, they're purpose-built by individuals for something, and then sort of disseminated and with appreciation for those of us that use them, they don't cleanly fall into these buckets that we were trying to fit them in. At least that's the thesis that I'm going to offer. And so, Karen, if you could tackle where does determinant begin and outcome end, or how that works, and Lydia, if you could tackle where does determinant begin and process end.
Yeah, it's a great question, and it is very confusing. And I think that Nielsen made it even more confusing by having the classical theories in the first place. I just think that has made it really complicated. But I think of CEPR, and maybe this is just because I, personally use it this way and have thought of it this way over the decades, or the years. But I think of it as really more determinate, that it is not, I don't think of it as an evaluation theory, because I think of the evaluation that happens in it as really trying to explain what the determinants were, to try and underscore that. Like when I think of REAIM, which in my head, and again, I'm ready to be corrected on this through our work together, but I think of REAIM, it is looking at specific targets, and what CEPR is doing, like how many did you reach, and how many of the doctors were engaged in delivering this thing. When I think of CEPR, I'm thinking of more trying to understand what got in the way of whatever the implementation outcome was. So it's not about the outcome achievement, it's like what led to that level of outcome. So it was the structure of the clinics or some of the resources that were available, or those kinds of things that really led to the outcome. So in my head, they're pretty distinct, but I think it is a little confusing that you can look forward or backward. I think that does make it a little more confusing, but I may be thinking about it too simply than others.
Yeah, perhaps not. I guess the only response I would offer is that sometimes REAIM type outcomes, and again, we're not sort of diving into them, but they can be very quantitative or very survey based or very, sometimes they're qualitative in their orientation, and like maintenance and implementation, and or some of the Proctor kind of additions that sometimes get added, and the quotes from them could look a lot like the quotes that you offered. And so only to just comment more than anything else that I like the distinction you offer, and perhaps that'll help us all think more clearly. But on its face, they may be a little bit more confusing. Okay, Lydia, you were second, and then we'll turn to the chat and to other people. Dawn has a question that we will pick on next. But Lydia, try and tackle this process versus determinant.
Well, I struggle with the same thing for sure in terms of sort of outcome or process / determinants. I may be being too simplistic in this as well, but I think EPIS may make it a little bit easier in that you're not evaluating the process so much as examining the role of the determinants, and you could also examine outcomes, but that's in a separate framework, the role of the determinants in your various phases. So the phases are almost about a time cycle, I guess defined by activities rather than, so you could define it by time and activities, I guess, ideally, rather than being the specific factors or outcomes that you're examining, if that makes sense. I think it's just a way, it's just providing you with buckets rather than being something specific that you're evaluating or quantifying.
Yeah, fair enough.
So organizing your thoughts, I guess.
Okay, so Dawn has a question about innovation, and Dawn, maybe I could ask you to just unmute and give a little color to this.
Yeah, well, I'm struggling a little bit with it. I was chatting to Natish that I have a fellow trying to get a K award, a mentee, and she's using EPIS, or do you say EPIS? I'm not actually sure. And when I first looked at it, it seemed like explore, prepare, implement, sustain. That's pretty intuitive. And then I saw CEPR, inner context, outer context. And then I got excited when I saw something about innovation, because I spent a lot of my time trying to bring innovative ideas into practice and then scaled up. But just from what you presented, it sounds like they're the same or very similar to what Proctor's implementation outcomes would say, or certainly drawn right from Everett Rogers and also found in REAIM. So I don't see what's new in EPIS. So can you help me out, especially with the innovation? I'd love to find some way to really bring the complexity of innovation into implementation and dissemination. That's a little provocative. I'm sorry.
It's a great
I'm
question.
struggling. I got to get it out.
So Lydia, we're going to maybe turn to you first, but if others have perspectives, So maybe I can rephrase Don's question, if that's okay with you, Don. So Lydia, maybe you can help us understand why you picked EPIS, not as a criticism, but as opposed to CFR or something else. And maybe that may be one way to begin to articulate the potential attributes of this that are useful for investigators.
Well, I think I could have picked CFAIR, but I really liked that the dynamicism of EPIS and its consideration of the sort of back and forth between all of the various determinants. A better reason to pick EPIS would have been that I really wanted to distinguish between the role and weight of those determinant factors at various phases of the implementation process. Like, for example, maybe like an ideal study, if I had more time and money, might be to really kind of map the evolution from our initial pilot to pretty wide scale up of this women's cancer early detection project in Rwanda, to try to understand, how did we just, we have been doing this a little bit, but how did we decide to scale up? When did we decide we were ready? What processes were needed for scale up that weren't needed for our pilot, for example, to really understand how the various phases of implementation went, whether successfully or not. And so I think that looking at it over time and looking at it over distinct phases of implementation is a nice feature of EPIS, that it's less explicitly stated in other frameworks.
Steve, please.
I'm not sure I have an answer to Don's usual great question. I don't, as you know, the field of implementation science, at least as I read it, was all about the so-called, gap between what we know already works and how to get it in place. It never, I think, and I'd be love to be corrected, was about innovating entirely new novel interventions. What we now are thinking about in terms of design thinking user-centered design, engaged design, things like that is becoming more part of the lexicon of implementation scientists. And I think it took us a while, I think, to get to the point where we figured out that maybe things aren't getting implemented because they never were designed properly, right? So this whole idea of design thinking and innovation at the front end. So I think that is a newer kid on the block from where it all started. I'm unaware, and I'd love to, Karen sits in a lot of these things as at NIH and Natish and others on this. I don't know that there's actually a specific framework that explicitly embraces innovation and design thinking at the front end as its fundamental premise, moving into implementation. And often the innovation is in the implementation strategies. That's a different conversation. It's not about the thing, it's about the strategy. So I don't know if that's helpful or not. I know how passionate you are about the area of innovation, but I think you are touching on maybe a bit of a disconnect that has been, I think, present in the literature for some time, if I read it correctly. But I'll stop there in terms of my own perspective.
And Steve, I'll just add that in the new CFR update, and I have not spent very much time with it yet, I will admit, but it has innovation as a core thing. I suspect it is, as you say, about the implementation, not about the thing. But we will maybe cycle back to this issue when we dig into that and explore it further.
Great, excellent. So we have a couple more minutes. Rebecca, please.
Hi, good afternoon. I'm sorry I'm not on video. I have to pick up my son. I'm an assistant professor of medicine. My background is in health communication. I'm really excited about the intersection between the two fields of health communication and implementation science. But I'm very new to learning about this field. I'm in your class, Dr. Chaturi, through the Catalyst. And I have a question kind of building on this conversation, because in my field, my expertise is all around hearing from communities, doing qualitative work, and then tailoring and culturally adapting. So I'm very focused on the thing, to kind of use the lingo. So my question is just kind of an offshoot of this discussion. where does the tweaking to the intervention, is that in the adaptation phase? Or any other insights on, again, how kind of the intersection of our two areas of health communication and message design, user-centered design, strategies like that, which someone like me is very conversant with, and the implementation world.
Yeah. So I'm gonna just tee up the question and ask, Karen or Steve or many others could answer this question. And so, where does the thing end and the way to do the thing begin? And it's a bit circular to some extent. And so, Karen, there may be clean ways, but how would you answer that question?
I'm so sorry. I got distracted by the chat. Can you say it again?
So Rebecca's
I'm just going to
question-
tell you as it is. I admit
Yeah,
it.
I appreciate the honesty,
Apologies.
as always. So the question is, when does the thing end and the way to do the thing begin? And the specific content that Rebecca asked about was health communication.
Yeah, right.
So
Yeah.
when talking to people about the thing, is that the way to do the thing, or is that the thing? I'm gonna sound crazy.
Yeah, I think as Rebecca laid it out, she first said, is that really the adaptation aspect? And I think about the changes that one needs to make as the adaptation phase. And, Kelly and Steve are both much more expert in that than I am. But I think what happens sometimes is that we make these adaptations because we think they're the right thing, but we don't study them, right? And we don't really think about the form and the function. And so we wind up with something very different that we're studying. So that's what I always worry about. And one of the reasons I've appreciated the formality that, our group here has thought about adaptation, because I think that really helps protect you a little bit. But I don't know enough about the way adaptation is happening in health communication to probably answer that question very well.
So I think, so Rebecca, maybe stay tuned, because I know Kelly and Steve did do an excellent thing about form and function last year, or maybe a little while ago, which I think we should probably revisit, because I think there's more to talk about there. And so maybe that we can reintroduce this idea. Okay, Shafika, last question or comment to you.
Yeah, sorry. I think my question to Lydia just sort of builds on the last two comments. And I'm not a user of EPIS, but the opportunities for evaluation along multiple parts of the framework. I was just wondering what Lydia's experience is in the field with the practicality of, you do the exploration and the planning, and you discover ways in which you might potentially have to innovate or adapt your implementation processes. So what are the practical constraints of actually acting upon that without sort of violating the thing or the intervention in a way that will improve your implementation ultimately? I don't know if I'm making sense, but that's, it's great to have these opportunities, but there are practical constraints when you're in the field. So I was just wondering if it's just a theoretical thing, or if there's been some exposure to trying to grapple with that.
I think I understand your question, and it makes sense to me. I mean, I think that there are a lot of practical limitations to this, perhaps most of all, that you're not always going to have the resources and ability to be assessing implementation throughout all the phases of implementation. But I think that what implementation science as a field would want you to do, but Natish and Karen and everyone else correct me, is make the adaptations that you need to make. Just write it down and note that you're doing it, I believe.
Perfect. All right, I'm going to end us there. Thank you, all of you, first of all, for being here and for participating. Thank you to Karen and to Julie and to Lydia for trying to make sense out of madness. And so just as a preview, we're hoping next month, there will be another session next month. We're hoping it'll be on CIFR or some CIFR 2.0 or something like that. But we welcome you back, and we'll send out announcements as soon as we've settled on a plan. Thank you.
And if anybody's really been digging in to CIFR 2.0, let us know, because we'd like to include you in developing that session. Yeah.
Be great. Perfect. Thanks, everyone. Have a great day.